Good morning, everyone. Thank you for giving me this opportunity. Now I'm going to present my topic is pupillary block post-complicated cataract surgery, two different clinical scenario. Pseudophakic pupillary block. The implanted intraocular lens is partially or wholly involved in the obstructions of the aqueous flow through the pupil. It develops in the days, week, month, or year after surgery. It may be due to the mechanical closure of the pupil by the IOL optic or post-op inflammation causing the formation of posterior synechia and adhesion between the pupillary margin and anterior IOL plane. Now I'm going to my case scenario first. 66-year-old man on post of 1 week, status post complicated cataract surgery, presented with the pain and dimness of vision. Vision was 636, IOP was 32 millimeter of mercury. On slit lamp examination, AC was very shallow with iris-cloth lens iris-collar in situ with non-patent PI. This is the picture. This is the AC was very shallow. So we diagnosed mostly probable pupillary block due to the non-patent PI. We did left YAC PI. Immediately post PI, AC was deepened. IOP became 16 millimeter of mercury. This is the picture. At the 1 month, vision became 6.6. IOP became 18 millimeter of mercury without AGM. This is the picture of 1 month. AC became deepened. This is the AIOCMT3 which is showing the PI was patent. AC became deepened. My another case scenario. This is 69-year-old man post of 1 day, status post complicated cataract surgery. IOL was in sulcus. On slit lamp examination, AC was very shallow, VH grade 1. We can see hazily vitreous blob blocking the pupil. Digitally, it was very hard. NCT was 42 millimeter of mercury. We diagnosed probable case of status post complicated cataract surgery with IOL in sulcus. We did multiple PI. AC became deepened. Post at the 1 week later, vision became 6.9, AC became deep, patent PI was there, NCT was 77. We can see the vitreous blob at the pupillary margin which is not touching the endothelium. At the 1 month, the same finding was there, fundus was not within normal limit. This is the picture of anterior segment. This is the AIOCMT which is showing the vitreous blob at the pupillary margin with PI, which is not touching the endothelium. We took for this vitreous blob for retina consultation because vision was 6.6. So they keep in close observation patient because there no traction was there. So just one study that telling that intraocular lens designed solely for the capsular bag, it should not be placed in the ciliary sulcus. It may cause the pigment dispersion, iris translumination defect, dysphotopsia, elevated intraocular pressure, intraocular hemorrhage, and cystoid macular edema. So in case of vitreous disturbance in sulcus, place single piece acrylic IOL PI should be done. Due to the risk of dissenting and posterior iris displacement, sulcus can precipitate relative pupillary block and chronic angle closure. So I'm going to tell my case scenario another. The 53-year-old male, history of 2 days post left YAC cap. Vision became 1/60. AT was 52 millimeter mercury. Before YAC cap, vision was 6.9 parts. IOP was 21 millimeter mercury. On slit lamp examination, corneal edema, bit dilated fixed pupil. AC was very shallow, but patient has inferior mild discented PCIOL. We given the oral glycerol, acetazolamide, topical AGM. Then we may be diagnosed pupillary block glaucoma, status post YAC cap. So we did the left YAC, multiple YAC PI was done. After 2 days, vision became 6/6. AT was 6 millimeter mercury with AGM. On slit lamp examination, cornea clear, AC was formed. Vitreous was present, but vitreous was present in the AC. So after 1 month without AGM, vision was 6.6, AT was 10 millimeter mercury. So just one case is rare case was reported which causes the, after 10 hours, patient reported back with the severe headache, right-sided periorbital pain and profound dimness of vision. They did the ND-YAG laser, now patient is fine. So YAG capsulotomy done beyond the IOL margin could be the region for vitreous to move anteriorly through the pupil and block the pupil. So it is recommended to perform a smaller capsulotomy within the anterior capsular rim with minimal energy. Anterior segment optical coherence tomography is an effective imaging tool for diagnosing and confirming the presence of vitreous in the anterior chamber and monitoring its status during the treatment. Thank you.
Thank you, Dr. Kajal. You have clearly emphasized the importance of YAC-PI in all these cases. YAC-PI definitely helps, and you have nicely described the mechanism why it occurred, especially the thing. And the vitreous blob that you demonstrated in the pupillary margin was very nice, and that's it. Like, there is no other thing that you could have done, and you have handled the
Only
cases
PI
well.
can
Yeah,
solve the prevention of the glaucoma, can prevention
yes,
of the
yes.
glaucoma.
You have clearly emphasized the need for PI in all these cases. Thank you.
Thank you, sir.
Yeah.